Lecture 6, Part 1, Kidney Diseases. The kidney are two bean-shaped organs found in vertebrates. They are located on the left and right in the retroperitoneal space, and in adult humans are about 12 cm in length. They receive blood from the paired renal arteries. Blood exits into the paired renal veins. Each kidney is attached to a ureter that carries excreted urine to the bladder. The nephron is a structural and functional unit of the kidney. It is composed of a renal corpuscle and a renal tubule. The renal corpuscle consists of a tuft of capillaries called a glomerulus and an encompassing Bowman's capsule. The renal tubules extend from the capsule. The capsule and tubule they're connected, and they are composed of epithelial cells with a lumen. A healthy adult has approximately to 1.5 million nephrons in each kidney. Blood is filtered as it passes through the renal corpuscle. The tubules have 5 anatomically and functionally different parts. The proximal tubule, which has a convoluted section, the proximal convoluted tubule, followed by a straight part section, proximal straight tubule. The loop of Henle, which has 2 parts, descending and ascending loops. The distal convoluted tubule, distal loop. The connected tubules and the collecting ducts. The tubule has adjacent peritubular capillaries that run between the descending and ascending portions of the tubule. Nephrons have 2 lengths with different urine concentration capacities, long juxtamedullary nephrons and short cortical nephrons. As the fluid from the capsule flows down into the tubule, it is processed by the epithelial cells lining the tubules. This process regulates the volume of body fluid as well as levels of many body substances. The interior of Bowman's capsule, called Bowman's space, collects the filtrate from the filtrating capillaries of the glomerular tuft, which also contains mesangial cells supporting these capillaries. These components function as the filtration unit and make up the renal corpuscle. The glomerular filtration barrier has 3 layers, as you see in the picture, composed of endothelial cells in pink color, a basement membrane, dark blue, and podocytes, green color. This is the cells of the Bowman capsule. And nearby you see the electronogram, and you see in this electronogram that the basement membrane also has 3 layers. First, lamina rara interna, and the third lamina rara externa. This is the light layer, and the medium lamina densa. The 4 mechanisms used to create and process the filtrate are filtration, reabsorption, secretion, and excretion. Filtration occurs in the glomerulus and is largely passive. It is dependent on the intercapillary blood pressure. About 1/5 of the plasma is filtered as the blood passes through the glomerular capillaries. 4/5 continues into the peritubular capillaries. Normally, the only components of the blood that are not filtered are the blood proteins and blood cells, red, white, and platelets. Over 150 liters of fluid enter the glomeruli of an adult every day. 99% of the water in that filters is reabsorbed. Reabsorption occurs in the renal tubules and is isopassive due to the diffusion or active due to the pumping against a concentration gradient. Secretion also occurs in the tubules and is active. Substances reabsorbed include water, sodium chloride, glucose, amino acids, lactate, magnesium, calcium phosphate, uric acid, and bicarbonate. Substances secreted include urea, creatinine, potassium, hydrogen, and uric acid. Some of the hormones maintain homeostasis include antidiuretic hormone, aldosterone, parathyroid hormone, atrial natriuretic peptide, and brain natriuretic peptide. A countercurrent system in the renal medulla provides the mechanism for generating a hypotonic interstitium. The final product is urine, which is conveyed through the collecting tubules into the renal pelvis. It is composed of water, metabolic waste, and toxins. The simple diagnostic tests indicating renal damage. Tests for the presence of the protein, red cells, hemoglobin, and polymorphs in the urine. Estimation of specific gravity and measurement of urinary output. Urinary cast. These are composed of foreign elements of various type, which are molded into cylindrical form by passage along tubules. The following types of cast have been indicated as you see in the picture: epithelial casts, granular casts, protein casts, red cell casts. And blood chemistry also can indicate pathological process in the kidney by the level of blood urea and creatinine level. The following causal factors can produce renal disease: infective, immunological, toxic, which may be endogenic or exogenic, metabolic, circulatory, and hereditary factors. Historically, kidney diseases, especially glomerulonephritis, were called bright diseases. The symptoms and signs of bright diseases were first described in 1827 by the English physician Richard Bright, after whom the disease was named. Kidney diseases are traditionally divided into following groups: nephritis, inflammatory diseases of kidneys, usually with involvement of glomeruli; nephrosis, pathological process of degenerative and necrotic nature affecting tubular epithelium; nephrosclerosis, characterized by sclerotic change localized in both glomeruli and tubules. As the classical classification principle cannot cover the all peculiarity of pathological processes in the kidney, the current nomenclature has been suggested. The change and clinical syndromes may be divided into 5 main groups. Glomerulopathy, pathological processes damage predominantly the renal glomeruli, for example, acute glomerulonephritis, nephrotic syndrome, diabetic nephropathy, etc. Glomerulopathies may be inflammatory and non-inflammatory. Tubulopathy, pathological process damage predominantly the renal tubules, as in acute tubular necrosis. Stromal diseases or interstitial nephritis, for example, tubular interstitial nephritis, pyelonephritis, etc. Congenital diseases, as ectopic kidney, fusion of kidneys, and tumors of kidney. Inflammatory glomerulopathy is called glomerulonephritis. The initiating agents can be divided into 2 categories: exogenic factors, for example, bacterial antigens as streptococci are the most commonly quoted agent, but staphylococci, Corynebacterium bovis, enterococci, Salmonella typhi, Treponema pallidum have also been incriminated. Viruses such as hepatitis B, measles, Epstein-Barr, parasites as malaria, toxoplasmosis, drugs as foreign serum, toxoids, endogenic factors. Disease resulting in immunological disorders the production of antibodies to cell components or secretions, as in rheumatic diseases, for example, systemic lupus erythematosus, rheumatoid arthritis, and so on, tumor growth, thyroiditis, etc. Classification of glomerulonephritis. According to clinical course, there are acute diffuse glomerulonephritis, subacute or rapidly progressive glomerulonephritis, chronic glomerulonephritis. According to clinical form, latent, hematuric, nephrotic, hypertonic, and mixed. Histological classifications depend on the localization of the process, subdivided into intracapillary glomerulonephritis, which may be exudative and proliferative. Inflammatory cells and epithelial cells proliferation is primarily in capillary tufts. And second one, extracapillary glomerulonephritis, also may be exudative and proliferative. Epithelial cells and inflammatory cells proliferation is primarily in Bowman's space. According to pathogenic mechanisms, glomerulonephritis may be immunological and non-immunological. Immunological glomerulonephritis may be due to the antibody mechanism or immunological glomerulonephritis of immune complex mechanism. And according to the bacterial factor, infection factor, there may be bacterial glomerulonephritis and non-bacterial glomerulonephritis. Glomerulonephritis arises sometime after the onset of the initiating disease, and an immune reaction has been provoked. Basically, the glomerular damage is due to the trapping of antigen-antibody complexes in the glomerular capillary network. Not all immune complexes will be trapped. The important factor is the size of the complex, and this will vary with the stage and intensity of the immune reaction. All are able to pass through the fenestrations of the capillary endothelium. Thereafter, the migration will depend mainly on their size and the degree of permeability of the basement membrane. The smallest molecule will reach a subepithelial position. The second type of molecules, this is medium size, is much more important in the meaning of glomerular damage. Such immune complexes accumulate in different parts of barrier, forming subepithelial, subendothelial, intermembranous, and mesangial deposits. The clinical symptoms can be divided into two groups, renal and extrarenal. Renal symptoms occur due to glomerular damage. This reduction in urinary output, oliguria, proteinuria, loss of protein with urine, hematuria. Extrarenal symptoms include hyperproteinemia, hypolipidemia, edema, hypertension, uremia, hypertrophy of left ventricle due to hypertension. The mechanism underlying the urinary symptoms are the following. Swelling of the endothelium leads to diminished blood flow and reduction in urine. It is oliguria. Inflammation affecting permeability of layers lead to hematuria. It is escaping of red blood cells and also occurrence of the red blood cell casts in urine. And focal loss of epithelium and endothelium also lead to loss of protein with urine, proteinuria, and loss of red blood cells, and also proteinaceous and red blood cell urinary cast in urine. Acute diffuse glomerulonephritis. This condition in its classical form follows 2-3 weeks after an infection, usually a pharyngitis or tonsillitis, caused by beta-hemolytic streptococci group A, so-called bacterial glomerulonephritis. It is commonest in children and young adults. Acute glomerulonephritis is a condition that appears to be an allergic reaction to a specific infection, most often a Lancefield group A beta-hemolytic streptococcal infection. Pathologic change occur predominantly in tufts. It is intracapillary exudative glomerulonephritis. Macroscopically, kidney enlarged, cortex is broad and pale with reddish dots, motley kidney. Microscopically, This is intracapillary exudative glomerulonephritis. Glomerulus is large, edematous with congested capillaries, a narrowed lumen. There are polymorph infiltration in capillaries and mesangial spaces. Leukocytes proliferation is indicated by the presence of the neutrophils and monocytes within the glomerular capillary lumen and often accompanies cellular proliferation. Endothelial cells and mesangiocytes may proliferate, and individual endothelial and epithelial cells undergo to necrosis. Glomerular basement membrane thickening appears as thickening of capillary walls on light microscopy. Electron microscope studies reveal deposits on granular material in the glomerular capillary walls. And hyalinization or sclerosis indicates irreversible injury. Clinical features may be relatively slight with some facial, preorbital edema, oliguria, the smoky and dark urine, and a moderate increase in blood pressure. Consequences of acute diffuse glomerulonephritis tend to vary with the age of the patient, usually precedes 1.5 to 6 months. Children almost always recover completely. In endothelial and epithelial change are reversed. The protein deposits are either excreted in the urine or are phagocytosed by mesangial cells. Capillary patency is restored. Complications usually occur in adult person. Complications as fibroid necrosis of capillaries arise in more than 1/3 of adults in acute phase. And also persisting proteinuria lead to chronic glomerulonephritis and in serious condition to rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis of subacute clinical course and usually end in fatal result. Rapid, usually irreversible, loss of renal function. Usually 50% decline in glomerular filtration rate within 3 months with glomerular crescent formation because this is the extracapillary proliferative glomerulonephritis. Rapidly progressive glomerulonephritis appears to arise mainly in the following circumstances. It may follow a streptococcal infection and in the early stage is indistinguishable from the acute diffuse glomerulonephritis. Associated with lung disease. This usually takes the form of Goodpasture syndrome, a condition almost exclusively confined to young adult males. There are repeated episodes of pulmonary hemorrhage causing severe anemia. Autoantibodies to basement membranes are present in the blood and are thought to be responsible for the renal damage. Death can be due to pulmonary or renal insufficiency. RPGN may associate with systemic diseases, for example, systemic lupus erythematosus and so on. Sometimes appears as idiopathic renal damage. Disease is of immunological mechanism. Extracapillary glomerulonephritis is characterized by the presence of potentially pathogenic antibodies or immune complexes in the plasma. These include the antiglomerular basement membrane antibodies, antinuclear antibodies, and antineutrophil cytoplasmic antibodies. Macroscopically, kidney is enlarged, mostly done in acute glomerulonephritis. Cortex is also broad, yellowish pale, with reddish dots, so defined big motley kidney. Many cases of rapidly progressive glomerulonephritis need a renal biopsy to make a diagnosis. Microscopically, RPGN is extracapillary proliferative glomerulonephritis with manifestation of the pathological change predominantly in Bowman's capsule space. Proliferation of epithelia of capsule with formation of crescents occur in almost all glomeruli. Strands of fibrin are prominent in capsular space, and adhesions between tufts and capsule are common. Tufts are compressed by crescents, capillaries become necrotic. There is a large amount of thrombi in capillary lumen. Gradually, tuft capillaries obliterate, and eventually glomerulus becomes a mass of hyaline fibrous tissue. The tubules present the same appearances as in acute diffuse glomerulonephritis, but focal necrosis is more common, probably due to ischemia caused by the glomerular lesions. Interstitial tissue becomes edematous and infiltrated by lymphocytes. These changes take place over a period of a few weeks and are progressive. Electron microscope examination reveals, as you see here, subendothelial and subepithelial deposits in the tuft capillaries and in the basement membrane, which is swollen, crinkled, and shows numerous breaks. Also, nearby you see the histochemistry shows us such greenish crescents, and beneath the histochemistry you see the histological appearances of the crescent, also shown by arrows. Initially, this condition is clinically indistinguishable from acute diffuse glomerulonephritis, but effects are much more evident and increase in severity. Most types of RPGN are characterized by severe and rapid loss of kidney function, with severe hematuria, red blood cell casts in the urine, and proteinuria associated with nephrotic syndrome. Some patients also experience hypertension and edema. Severe disease is characterized by oliguria and anuria, which portends a poor prognosis. Death due to hypertension and uremia is almost inevitably within a matter of weeks or year, depending upon the progress of the pathological change and the occurrence of complications. Complications are those of uremia, superadded infection, fibrinous pericarditis, and anemia. Malignant hypertension may supervene, intensifying the renal change and also causing cardiac hypertrophy, may lead to heart failure. The usual and frequent death reason is a coma. Chronic glomerulonephritis usually develops as primary disorder, but may occur at the final stage of other types of glomerulonephritis. Disease proceeds over 12 months, and chronic renal failure is the end result. Uremia is the main clinical feature, but hypertensive cardiac failure or cerebral hemorrhage may cause death. Chronic glomerulonephritis is the third leading cause of the chronic kidney disease and accounting for about 10% of all patients on dialysis. And histologically, pathological process is located in tufts, this intracapillary proliferative glomerulonephritis. The most common forms are mesangial and fibroblastic glomerulonephritis. In this form, there are generalized change caused by deposition of immune complexes in the glomerular capillary basement membrane and mesangium, as it is the intracapillary proliferative glomerulonephritis. According to level and character of this morphological change, there are the following types of mesangial glomerulonephritis. Minimal change glomerulonephritis, although the clinical appearances are the same that in all examples of the nephrotic syndrome, but the apparent lack of microscopic glomerular change gave rise to the term minimal change disease. Mesangium slightly enlarged due to deposition of immune complexes, increasing of mesangial matrix, and minor proliferation of mesangiocytes. Minimal change disease can be estimated as initial stage of mesangioproliferative glomerulonephritis. Second, mesangioproliferative glomerulonephritis is the commonest type of glomerulonephritis. Usually, the latent and hematoric clinical course is much more characteristic. Microscopically, there is increasing of mesangial matrix and a proliferation of mesangiocytes, focal thickening and gummating of capillary basement membrane. and histochemistry reveals the deposition of different immune globulins, maybe IgG, IgD, IgM, in capillary basement membrane and mesangium. Third, mesangiocapillary glomerulonephritis. Prognosis is bad, with progressive development of renal failure in a short period of time. In contrast to mesangioproliferative glomerulonephritis, thickening and garmenting of capillary basement membrane occur diffusely and appear due to mesangial interposition. Lobular glomerulonephritis may be accepted as another type of mesangiocapillary glomerulonephritis and characterized by irregular thickening of glomerular basement membrane by interposition of mesangial cells between endothelium and basement membrane, enlargement mesangium at the central part of tubes, thus glomeruli assume the lobular structure. The specific form of the mesangial proliferative glomerulonephritis is the Berger disease, which we discuss in the next slide. Fibroblastic glomerulonephritis, otherwise sclerotic or terminal glomerulonephritis, occurs as end stage of all types of chronic glomerulonephritis. Immune globulin A nephropathy, or Berger disease, the special type of mesangial-proliferative glomerulonephritis, which affects young adults and is characterized by deposition of immune globulin A in tufts. This usually results in hematuria and resistant proteinuria. Immune globulin A disease may occur primarily, idiopathic Berger disease, or secondarily to systemic diseases. Aggressive Berger disease can attack other major organs such as the liver, skin, and heart. A variety of systemic disease are also associated with Berger disease, such as liver failure, cancer, celiac disease, systemic lupus erythematosus, rheumatoid arthritis, heart failure, etc. In non-aggressive immune globulin A nephropathy, there is a slow progression to chronic kidney failure in 25-30% of cases during a period of 20 years. Secondary cause infective endocarditis, vasculitis, and connective tissue diseases. Histologically, immune globulin A nephropathy may show mesangial widening and focal and segmental inflammation. Diffuse mesangial proliferative glomerulonephritis may also be present. As you see in the picture, immune fluorescent shows mesangial deposition of immune globulin A, often with C3 and properdin, and smaller amounts of other immune globulins, IgG or IgM. Electron microscopy confirms electron-dense deposits in the mesangium that may extend to the subendothelial area of adjacent capillary walls. There is the microscopic appearances in fibroblastic glomerulonephritis. Some mesangiocytes are converted to fibroblasts and produce collagen fibers. Ultimately, the glomerulus becomes completely sclerosed. This is called nephrosclerosis. The process starts in juxtamedullary glomeruli, but spreads peripherally to outer cortical glomeruli. Arterial and arteriolar sclerosis, accompanied to glomerulosclerosis, interstitial fibrosis, and lymphocytic inflammation. Associated tubules undergo atrophy and thyroidization. The condition is unresponsive to steroids and ends in chronic renal failure. Non-inflammatory glomerulopathy. Pathogenesis of these disorders is not based on inflammatory change. These are manifested in the following forms: lipoid nephrosis, membranous nephropathy, and focal segmental glomerulosclerosis. Microscopic changes depend on the types of nephrotic syndrome. Membranous nephropathy, idiopathic nephrotic syndrome of adults. The term membranous nephropathy reflects the primary histologic change noted on light microscopy: glomerular basement membrane thickening with little or no cellular proliferation or infiltration. Membranous nephropathy is most often primary, although it has been associated with hepatitis B, antigenemia, malaria, autoimmune diseases, thyroiditis, heavy metals, lupus diseases, malignancy, certain drugs such as non-steroid anti-inflammatory drugs, gold, captopril, etc. Pathogenic mechanism: idiopathic autoimmune disease linked to HLA caused by antibodies to renal autoantigens. Macroscopically, enlarged and general pallor due to edema is evident, and microscopically several stages can be recognized. In the early stage, tufts enlarge, mesangial matrix slightly increase. There are generalized changes in the glomerular capillary basement membranes with subepithelial deposits. Increasing basement membrane material between deposit can be seen as spikes. This process is referred to as membranous transformation. Immunofluorescence exhibits granular, diffuse peripheral deposits, usually IgG and C3. In this slide, you can see the gross appearances, big white kidney, and microscopical change. You see the proximal convoluted tubules contain hyaline droplets, reflecting protein reabsorption. Lipid globules appear in the tubule epithelium. Lipid is also found in the interstitial tissue. The disease is only slowly progressive, but ultimately many glomeruli and associated tubules have been eliminated by destruction and sclerosis. Chronic renal failure and uremia develops. Originally, focal segmental glomerular sclerosis is regarded as a variant of minimal change nephropathy. Multiple associations described as etiology: infection, human immune deficiency, virus, drugs, anabolic steroids, heroin, vascular and metabolic disease, genetic conditions, and so on. No single pathogenic trigger has been identified. Clinical features are high incidence of nephrotic syndrome and renal insufficiency. Renal biopsy is required for diagnosis. In focal segmental glomerular sclerosis, a segment of glomerulus undergoes sclerosis without inflammation, but with an increase in mesangial matrix. As you see in the microscopic slides, at least one glomerulus with segmental collapse of the tuft, obliteration of the capillary loops, and overlying podocyte or parietal cell hypertrophy or hyperplasia occur. May appear as pseudocrescents filling Bowman's space. Lipoid nephrosis, otherwise idiopathic nephrotic syndrome of children, or food process disease, Neal disease, or minimal change disease, occurs mainly in children but is occasionally seen in adults. It is the commonest cause of the nephrotic condition in children. Etiology is usually idiopathic, especially in children. Secondary forms can be due to virus, drugs, allergic reactions, immunologic diseases, and neoplasia at all ages. Really, it may be of familial gene mutations. Occasionally, it may follow vaccination, but is not related to any particular type. Development mechanism is non-immunologic. Despite the clinical appearance of nephrotic syndrome, there is little or no evident microscopic abnormalities of the kidneys. Basement membrane not thickened without immunoglobulin deposits. The accurate diagnosis is established only by electron microscope, which reveals the podocytes have lost food processes and attached directly to basement membrane. There are proteinaceous vacuoles in cytoplasm of podocytes. Clinical manifestation. The clinical features are the same as in a nephrotic process. Gross proteinuria with hypoalbuminemia and hypolipidemia leading to severe edema. The proteinuria is highly selective. Only albumin being found in the urine and is apparently due to increased permeability of the glomerular capillaries. Lipid-rich protein casts appear in the urine, lipiduria, but usually there is no hypertension, no hematuria, and no azotemia. Microhematuria is more characteristic. In adults, it can present as acute renal insufficiency. Prognosis, the condition in children responds to steroid therapy. It tends to recur, and the prognosis depends on the frequency of recurrence and the duration of the interval between attacks. Rarely, if ever, leads to end-stage renal disease without development of focal segmental glomerulosclerosis. In adults, the prognosis is not so clear. Acute renal failure relapse is common and often lead to steroid dependence. Chronic renal failure, also called chronic kidney disease. This clinical state is reached when the functional tissue of the kidneys have been reduced to level where life cannot be maintained, and chronic kidney disease can progress to end-stage kidney failure, which is fatal without hemodialysis or a kidney transplant. The primary morphological change occur in glomeruli and can be manifested as sclerosis and hyalinosis of glomeruli with shrinkage of kidney. It is nephrosclerosis. Nephrosclerosis may originate in two conditions. First, nephrosclerosis of vascular origin, primary nephrosclerosis, occurs in hypoxia due to depletion of blood supply of kidney. In atherosclerosis, hypertension, inherited developmental abnormalities of renal artery, etc., result in shrinkage of kidney. And parenchymatose or glomerular nephrosclerosis, secondary nephrosclerosis, develops due to previously existed disease of kidney. For example, chronic glomerulonephritis, amyloidosis, diabetes, etc. All types of nephrosclerosis eventually result in chronic renal failure and uremia. The both kidneys are
Siz burada
small, white and firm,
morfologiyasını
with a
görürsünüz
granular
öyrəndirilməsini.
fine surface.
Görürsünüz ki, qabıq
Capsule is
maddə çox
adherent
nazili
and strips with
və
difficult.
ləyən genişlənib.
Cortex is narrowed and irregular.
Qabıq maddə bilirsiniz ki,
Pelvis
mıxçıqlar
is
qabıq
dilated.
maddədə yerləşir. Sinus.
Clinical manifestation of uremia is the following. The patient is lethargic, anorexia, nausea and vomiting, itching, skin diathesis, calciphylaxis, uremic frost are usual, followed by mental confusion, muscle twitchings, convulsions, and death. More commonly, a milder but inevitably progressive condition exists. Complications. Hypertension. This is almost inevitably and several consequences. Malignant hypertension, left ventricular hypertrophy, cardiac failure, cerebral hemorrhage are possible. Fibrinous exudates, for example, fibrinous pericarditis, heavy heart, uremic pneumonitis with pleural exudate, pseudomembranous colitis, hemorrhagic ulcers of the gastrointestinal tract, lack of hematopoietin production in the kidney causes anemia, decreased immune response which makes patient more vulnerable to infection, damage to central nervous system which can cause personality change or seizures. Acute kidney injury. This is a clinical term. Other names: acute renal failure, acute cortical necrosis, is an abrupt loss of kidney function that develops within 7 days. The causes are numerous. Acute tubular necrosis follows different diseases leading to tubulopathies, necrotic nephrosis, rheumatic or systemic diseases, rapidly progressive glomerulonephritis, GIC syndrome, etc. Effects of tubular damage are the gross biochemical change as loss of mechanism, controlling balance of electrolyte, water and urea, absentine acid-base balance, loss of substances in urine normally completely or almost completely reabsorbed, glucose, potassium, amino acids, proteinuria due to damage to associated capillaries. It must also be apparent that glomerular lesion and pathological change in the renal pelvis will upset tubular function by interfering with blood supply. Acute tubular necrosis arises as complication of different pathological conditions and may be classified as either ischemic or toxic. Ischemic ATN occurs when the tubular cells do not get enough oxygen. Shock state of any reason, for example, due to hemorrhage, burn, trauma, acute intestinal obstruction, compatible blood transfusion, abdominal operations, etc. Toxic ATN occur when the tubular cells are exposed to toxic substances. This is nephrotoxic ATN, and application of the following toxic substances, for example, carbon tetrachloride, triene, ethylene glycol, compounds of mercury, uranium, chromic acid, and various drugs, or crash syndrome, etc. The lesions are the direct result of the poison, an action of which is intensified by the concentrating activity of the tubules. Patterns of tubular damage in ischemic and toxic acute tubular necrosis differ. In the ischemic type, tubular necrosis is patchy. Relatively short length of tubules are affected. Straight segments of proximal tubules and ascending limbs of Henle's loop are most vulnerable. In toxic acute tubular necrosis, extensive necrosis is present along the proximal tubule segment with toxins, some toxins, but necrosis of this distal tubule, particularly ascending Henle's loop, also occurs. Here's the illustration of the ischemic and toxic type of acute tubular necrosis. The causes of acute kidney injury nowadays are categorized into prerenal, intrinsic, and postrenal. Prerenal causes of acute kidney injury, prerenal azoturia, are those that decrease effective blood flow to the kidney and cause a decrease in the glomerular filtration rate. Notable causes include low blood volume, as in dehydration, low blood pressure, heart failure leading to cardiorenal syndrome, liver cirrhosis, renal artery stenosis, and renal vein thrombosis. Intrinsic or renal acute kidney injury refers to disease process which directly damage the kidney itself. Common cause of each are glomerulonephritis, acute tubular necrosis, acute interstitial nephritis, rhabdomyolysis, calcineurin inhibitors. Postrenal refers to acute kidney injury caused by disease states downstream of the kidney and most often occurs as a consequence of urinary tract obstruction, benign prostatic hyperplasia, kidney stones, obstructed urinary catheter, bladder stones, or cancer of the bladder, ureters, or prostate. Pathogenesis. There are three phases of development of pathological condition: onset, anuria, and restoration of diuresis. Onset, the glomerular filtration rate is gradually reduced, and as a result, oliguria develops. Unselective reabsorption of the filtrate occurs through the damaged tubule. Anuria. The process develops to the complete impairment of glomerular blood supply, which result in destruction of deprived tubular epithelium. The effects are edema, upset in electrolyte balance, eventually uremia. Restoration of diuresis. This occurs following healing of the lesions. The damaged tubular epithelium is replaced by a simple type which has not yet developed selective activities. Therefore, large volume of the dilute urine are passed. Mechanisms of development of clinical appearances in different these phases of acute tubular necrosis you can find in your textbook. Morphology. The gross appearances of the kidneys is the same in both groups, although there is some difference in the type and distribution of the lesions. Kidneys enlarged, swollen. Pathologic kidney specimen showing the cortex contrasting to the medullary tissue. As you see, cortex is pale, medulla gets the bright red coloration. And pay attention to microscopic slide. Microscopically, at the beginning phase, some of tubular epithelial cells undergo to the proteinaceous and fatty degeneration. But in this slide, you see the acute phase. In acute phase, the tubular epithelial cells are necrotic and being flushed into the tubular lumina with excretion of cylinders in urine. The basement membrane may be ruptured. Tubularexis occurs. Interstitial nephritis is inflammation of the kidney's interstitium. It is uncommon in patients without any symptoms, but occurs in about 10–15% of hospitalized patients with acute kidney injury of unknown cause. In addition to providing a scaffolding support for the tubular architecture, the interstitium has been shown to participate in the fluid electrolyte exchange as well as endocrine functions of the kidney. The most frequent types of the interstitial nephritis are tubular interstitial nephritis and pyelonephritis. Tubular interstitial nephritis. Common causes include infection or reaction to medications such as analgesic or antibiotics. There are a variety of known factors that can provoke the inflammatory processes within the renal interstitium, including pharmacologic, environmental, infectious, and systemic disease conditions. Interstitial nephritis may present with a variety of signs and symptoms, many of these non-specific. More specific symptoms such as flank pain, pain with urination, and visible blood in the urine, as well as signs like hypertension, can be helpful in diagnosis. Other conditions that may develop include a high concentration of the potassium in the blood, metabolic acidosis, and kidney failure. The only way to definitely diagnosis is kidney biopsy. Pathologic examination will reveal the presence of interstitial edema and inflammatory infiltration with various white blood cells, including neutrophils, eosinophils, and lymphocytes. Generally, blood vessels and glomeruli are not affected. And electron microscope shows mitochondrial damage in the tubular epithelial cells, vacuoles in the cytoplasm, and enlarged endoplasmic reticulum. In chronic tubular interstitial nephritis, the most serious long-term effect is kidney failure. When the proximal tubule is injured, sodium, potassium, bicarbonates, uric, and phosphates reabsorption may be reduced or damaged, resulting in metabolic acidosis, low potassium, hypouricemia, and hypophosphatemia. Damage to the distal tubule may cause loss of urine concentrating ability and polyuria. Glomeruli are involved. Subsequently, salt-losing kidney phenomena is developed. In most cases of acute tubular interstitial nephritis, the function of the kidney will return after the underlying disease is cured. But chronic tubular interstitial nephritis has no cure. Some patients may require dialysis. Eventually, a kidney transplant may be needed. Pyelonephritis is a commonest type of renal disease and probably also the commonest single cause of renal failure. Two phases of disease can be clearly defined, acute and chronic, but there is a spectrum of change and the division into phase is arbitrary. Acute pyelonephritis. This is an acute pyogenic infection of kidney. The commonest infectic organism is Escherichia coli, but other fecal bacteria may also be found, Pseudomonas, Streptococcus, and so on. Routes of infection are ascending, hematogenic, and lymphogenic. In the majority of cases, the condition is an ascending infection from the lower urinary tract, frequently associated with obstruction. Both sexes may be affected. The condition is more common in females, possibly due to the short, wide ureter. In the male, obstruction is almost always present. Obstruction of the urinary tract promotes infection and catheterization is commonly carried out in these cases and can introduce infection. In these cases, the infection is likely to be mixed. Microscopically, there are presence of suppuration on cortex and medulla. Inflammation is mainly interstitial. Glomeruli are usually unaffected, pale streaks with surrounding congestion in medullary rays, mucosa of pelvis, and calyces acutely congested and swollen with lympholocytic infiltrations. Macro and micro abscesses and hemorrhages can also occur. Some tubules are destroyed, others filled by pus cells. Large numbers of bacteria are found in the urine, pyuria, several 100,000 per milliliter in the urine, in acute phase. Involvement of the interstitial tissue and destruction of the tubules make resolution impossible, and healing by a form of granulation tissue is usual. Chronic pyelonephritis is essentially the result of repeated attacks of inflammation and healing. Depending on the cause, only one or both kidneys may be affected to variable degrees. Macroscopically, there is a progressive contraction of the kidney due to fibrosis, which becomes grayish-white. In cases with urinary obstruction, the external size of the kidney may remain normal or even be increased. The minority of cases are of this type. Microscopically, the following lesions are seen in most cases. Change similar to those seen in the healing stage, but more advanced and extensive. Periglomerular and peritubular fibrosis, heavy lympholocytic filtration, absence of the tubules, obliterating endoarteritis are revealed. Pelvis mucosa is thickened and granular. Acute suppurative lesions cysts appear due to the recent infection. Foci of the dilated tubules in the cortex occur due to destruction of the collecting tubules, so that they end blindly. Upper tubules, delayed, develop keloid casts and come to resemble thyroid tissue, and thyroid kidney phenomena develops. The patchy inflammation results in fibrosis and atrophy irregularly distributed throughout the cortex and medulla. Renal failure with uremia develops, where unilateral obstruction is the cause. Only one kidney is affected, and uremia is not a feature. Hypertension in common conditions. 90% of patients are hypertensive. Renal failure occurs. Where the inflammation is confined to one kidney, its removal has relieved the hypertension in some cases. Congenital disorders of kidney. Malpositions and malformations of the kidney are relatively common, and the variations are numerous. Some of the commoner are ectopic kidney or pelvic kidney. One or both kidneys fail to reach the normal adult position. Fusion of kidneys. This is usually partial, producing the so-called horseshoe kidney. The ureters may be partially obstructed, leading to hydronephrosis, infections, and calculi formation. Single kidney. This may be a form of fusion, and there may be two ureters. In other cases, there is absence or agenesis of one kidney, usually the left. There is no interference with renal function unless, of course, the single kidney becomes diseased. Polycystic kidney disease is an inherited disorder in which clusters of cysts develop primarily within kidneys, causing kidneys to enlarge and lose function over time. Cysts are non-cancerous round sacs containing fluid. The cysts vary in size and they can grow very large. These are the examples of congenital kidney diseases. Hemodialysis is a treatment to filter waste and water from the blood. Hemodialysis helps control blood pressure and balance important minerals such as potassium, sodium, calcium in the blood. Thank you for attention.